Okay, today we talk about vaginal birth after cesarean section. This is a really hot topic. It's a hot topic because we have a lot of cesarean sections that we are doing. We know that in most tertiary institutions, the cesarean section rate is around 30%. So a lot of patients are having these cesarean section, and if they have cesarean sections, they are coming back again to labor ward with those cesarean section with a high risk. We know that the risk of rupture for cesarean section in our setup, there are some studies that have been done, is above 1%. So that is really high considering the high morbidity and mortality that we see associated with cesarean section. In addition, in our setup, we see very few planned vaginal births after cesarean section. Most of the patients that come to our facilities come with their previous cesarean section and already in labor. And we have to decide, are we going to do a trial of labor in this patient, or we are going to take them straight to theater after admission. So that's the setup that we have existing. We have a few patients, of course, who come in the antenatal clinic and they've been followed up as previous cesarean sections, and we get to plan how we are going to deliver them around 36 weeks. We go through a checklist. We see the risk of vaginal delivery versus elective repeat cesarean section, and then we decide together with the patient which way that we should go. Should we give them an elective repeat cesarean section, or they should have a trial of labor? And again, in our situation, in our African setup, we see that most patients want really to try labor. They want to try labor because sometimes in the community, they are told that if you get all your deliveries by cesarean section, then you are not woman enough. So there's always a large percentage of women who just want to try labor. So once our majority of patients, as usually is the case, come into labor ward, maybe already in latent phase of labor or in active phase of labor, and their previous cesarean sections, we need to go through a checklist. This is very similar to a checklist we would go through in the antenatal clinic in a patient who has come early. So we'll go through that checklist, and we'll start with just, you get the general demographic of the patients. Where do they stay? Where do they come from? You need to check their parity. So parity is important because when we have a high parity, then usually we don't want to do a trial of labor if somebody has a cesarean section. So high parity in our setup again usually means P5 and above. So anyone who's having a parity of 5 and above, that kind of patient will not will be advised that it's better they do a cesarean section instead of having a trial of labor. The other thing associated with parity is again the number of living children. So if somebody has a bad obstetric history, they've had so many pregnancies and they don't have a living child, usually in this situation, most senior gynecologists who give that patient advice to go for cesarean section other than a vaginal delivery. The reasoning there is that our monitoring is very poor and the risk of rupture is high. So if somebody has no living child, they have had several fetal losses, most would just say go for cesarean section as opposed to vaginal delivery. We also have to look at the age of the patient. Usually older patients end up with failed trial of labor, so that is important. And then we need to look at the other thing about parity is those para 1 gravida 2s. It means that they've had no vaginal birth before. So it means that that patient might end up with a cesarean section. Their risk of cesarean section is very high. So even if you try labor, the success rate is quite low, maybe less than 60%. So those patients might need to be advised for cesarean section. But like I said, in our setup, most women really want to try, especially after their first cesarean section. They want to see if they can have a successful vaginal birth. So that is about parity. And we've talked about age already. Age above 40, age above 45 is something you need to look at and talk to the patient on whether they want to do a trial of labor or not. The other thing people talk about, which I'm mentioning only to discourage, is that you don't do a cesarean section just because the patient wants a BTL. Bilateral tubal ligation has high morbidity, has lower morbidity, than cesarean section. So you won't take a patient for cesarean section just because they want a bilateral tubal ligation. So if that's the only thing they want, then maybe you can do a trial of labor, and then after they deliver, they can have a tubal ligation. So that's about the basics that you need to take in the demographics. The other things that we need to look at is the number of previous cesarean sections that the patient has had. So if a patient has had more than one cesarean section, again, in our setup, we just send this patient straight for cesarean sections. So 2 previous cesarean sections, 3 previous cesarean sections, 4 previous cesarean sections, these patients go straight for cesarean section. We don't do a trial of labor. Then patients with twin pregnancies, we don't do a trial of labor. Patients with any malpresentations, malpositions, we don't do a trial of labor. We ask these patients to go for cesarean section. So if you have a breech in previous Caesar, you have a twin pregnancy in previous Caesar, you have face presentation, you have brow presentation, any of these malpresentations all end up going for cesarean section. Of course, every other thing that does not deliver vaginally, we don't allow for cesarean section. So that means that all the patients with placenta previa, all patients with big baby in previous Caesar, big babies are usually babies above 3.5 kg estimation, and this patient has a previous Caesar. All these patients might not be allowed to go for cesarean section. Again, the risk there is ruptured uterus. So that's about looking at the history of the previous pregnancies and looking at the history of the present pregnancies. Then we need to look at the surgical history of the patient. Have they had a myomectomy? Have they had any surgery on the uterus? Have they had a classical cesarean section? So if somebody has had a myomectomy, they've had a classical cesarean section, those patients go straight for cesarean section. We don't allow them to go for vaginal delivery. So how do you know in the history that this patient had a classical cesarean section? Usually we look at, because the patient wants it, so we look at what time the cesarean section was done. Was the cesarean section done preterm, or was the pregnancy term? So preterm cesarean sections, many times, again, the patient won't say usually, and you might end up looking at the weight of the baby after delivery. So if you look at the weight of the baby, it can give you an idea. The baby was 1 kg, the baby was 1.2, maybe that was a preterm delivery. Then the other thing that gives you an idea is somebody was had Preterm, they were draining, and they ended up with a C-section. That gives you an idea that that cesarean section might have happened preterm, and therefore it might not have been a lower segment cesarean section versus a classical cesarean section. The other thing you need to get in the history is to help you know if there was a classical is the indication. So was the indication transverse lie? Transverse lies are difficult deliveries. Sometimes we have extensions and so on, and we know in our setup we'll never get the notes on how the Caesar was done, what were the complications of the Caesar. So we are using all these parameters. Was it a transverse lie or not? If it was a transverse lie, then sometimes you think maybe there was an extension, maybe there was a classical C-section done to try and extract the baby. So we need to be careful about a trial of labor in these patients. The other surgical history we need to look at is the ectopic pregnancy history. If the patient had an ectopic pregnancy, of course 98% of ectopic pregnancies are in the tubes and they don't really matter, but we need to know that if the ectopic was cornu, then that patient might need to go for cesarean section versus a trial of labor. Again, in our setup we don't have notes to indicate where the ectopic was and so on, so we just have to get as much information as possible. So even the previous surgeries, the previous cesarean sections that this woman had, we need to dig again into the information on what were the complications of that cesarean section, the previous cesarean section we are concerned about. Was it accompanied by infections? Did the patient see any pus in the vagina, pus in the wound? How long did they stay in the hospital after cesarean section? How long were they kept in the hospital? Did they have a readmission after the cesarean section? All this information makes us think about whether there was a complicated cesarean section or not, and therefore makes us think about, is this patient going to try labor or end up with a repeat cesarean section? So that is also important. The other important thing about the previous cesarean section and this actual delivery that is happening now is the interdelivery interval. I think we look at the interdelivery interval and think about people saying that the scar is not strong enough and the amount of time we are using is 18 months. So if we have a woman having an interdelivery interval, so meaning from the time they delivered last time to their current delivery, is there 18 months in between? If there's 18 months and more, we think that the interdelivery interval is long enough, and therefore we can do a trial of labor in this patient. If the interdelivery interval is too short, then we advise that the patient doesn't try labor and maybe goes for a repeat cesarean section. So those are the parameters that we are looking at before we decide which way we can go. Do we go for a cesarean section, or do we make this patient undergo a trial of labor? So that's how we go about it. Now, when this patient, like we've already said, is already in labor, then we need to really monitor this labor closely. We need to monitor the fetal heart every 30 minutes. If we have a CTG, which we don't have in many cases, then we can put electronic fetal monitoring that is continuous on the patient, because the first thing that happens when we have a fetal compromise, what we suspect really is an impending rupture. So we are looking out for fetal compromise by checking the fetal heart every 30 minutes. And if we have a continuous monitoring, we we continue doing it. Then we need to have members of staff that can diagnose a rupture easily, because that's really the big disaster that can happen in this previous Caesar. So, things like a descent that was good becomes worse. So patient was +1 descent, now they are 0, and so on. All those things can indicate a ruptured uterus. Contractions that disappear can indicate uterine rupture. Sometimes abdominal pain, severe abdominal pain, sometimes vaginal bleeding. All these can be signs of uterine rupture. So we need to look out for these things. Of course, we need to always continuously monitor the vitals, the pulse of the mother every 30 minutes. We need to continue the blood pressure of the mother, usually every hour or so, to just have a proper surveillance for uterine rupture. And also we need to follow the pathograph to the book. There's an alert line there, there's an action line. We just need to follow the pathograph by the book. We need to remember that in our setup we don't augment cesarean sections for the same reason we've talked about. The risk of rupture is high, and we don't induce cesarean sections as well for the same reason. We don't put oxytocin on a previous Caesar, and we don't induce a previous Caesar. So that's the situation with these previous Caesars. So we monitor the patient, looking out for rupture, looking out for abnormal fetal heart, and if we detect any of these things, we stop the labor, we take the patient to theater. And as part of the preparation, of course, we need to make sure that this patient has IV lines. We need to make sure that this patient has blood prepared, at least they're grouped and saved, so that if there's need for blood, that is done. That is, blood is already available. So that's how that normally works. So before a patient goes for cesarean section, and like we said, we don't have an opportunity many times to see these patients in the antenatal, but we can do quick counseling of the patient. So we need to look at the risk of VBAC itself. Then the big thing is rupture. The patients need to know that the risk of rupture is about 1%. And they need to know that the success rate is around 60 to 80%. And if that fails, then they end up with a cesarean section. Then we need to tell them about the fact that people who go for cesarean section have risk of bleeding, risk of infection, risk of reduced bonding with the baby, because usually we separate baby and mother during cesarean section, and risk of organ damage, especially with previous Caesar. The adhesions, the anatomy is not perfect, so this patient might end up with bowel injury, ureteric injuries, bladder injuries, and so on. So all those risks need to be known to the patient. There's also the risk of anesthesia that is associated with cesarean section. If they end up with a vaginal delivery, of course, they bond better with the baby, they go home earlier, their risk of bleeding is less, and the risk of postpartum hemorrhage is also less with vaginal delivery compared with cesarean section. So these are risks the patients need to know about. They need to know what's happening, benefits and problems with cesarean section versus benefits and problems with a vaginal birth. And then they need to make an informed decision. Really, these VBACs are risky, and if a woman chooses to go for cesarean section, we don't have any we shouldn't have any problems offering a cesarean section to a woman who has decided to go for cesarean section as opposed to vaginal delivery after a cesarean section, because the risks are really high. Our labors are poorly monitored, and if a patient chooses a cesarean section, usually we shouldn't have any problems with that. So counseling is important, and respecting the woman's wishes when we deal with vaginal birth after cesarean section is quite important. Yeah. Lastly, patients need to know about the what happens in the next pregnancy once they get this second cesarean section. So they're getting at least a second cesarean section. Again, that's in our setup. So if they get a second cesarean section, the next pregnancies or the other pregnancies will be delivered by a cesarean section. They need to know that when they come for their third cesarean section, the risk of bowel injury, bladder injury is higher, and they just need to understand those issues when they come back, that they are not trying a vaginal delivery again after this second cesarean section. So generally, those are the basics on VBAC and counseling a patient that will be undergoing a VBAC. Thank you for listening, and we will see you next time.